Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. On this week's video, I want to review with you a fascinating subject, and that has to deal with permanent impairments of the upper extremity, specifically related to carpal instability. Carpal instability. And actually, today's video training completes a long-term series on the instability syndromes. If you're familiar with these video trainings, you'll recall that we've already done video trainings on shoulder instability. We've done trainings on patellar instability. We've done training on knee instability due to medial and lateral collateral ligament laxity and anterior and posterior cruciate ligament laxity. We've done video training on ankle instability. We've done video trainings on all of the spinal instabilities. And so today's video training on carpal instability completes the entire series of the instability syndromes that are described in the AMA guides. And carpal instability, to me, is a particularly fascinating topic. And I say that because in speaking with many doctors up and down the entire state, I find that permanent impairments due to carpal instability are many times overlooked impairments and underutilized impairments. And the reason that permanent impairment due to carpal instability is many times overlooked or underutilized is because many doctors do not have a specific, focused, and targeted physical examination procedure for the identification of carpal instability. Many doctors have not templated the procedure for ordering the necessary diagnostic studies that are required by the AMA guides for the assessment of carpal instability. And many doctors are just not that familiar with the pathoanatomy involved with assessing for carpal instability. So today's training comes at a perfect time. Over the past 2 weeks, on 3 separate and independent occasions, I've received inquiries from my subscribers asking for additional elaboration on the topic of carpal instability. So today's video training comes as a direct response to subscriber requests. And before we get into today's material, I just want to let you know that if there's a topic or an issue or a concern that you have regarding your QME practice, I'd love the opportunity to possibly help you out and perhaps even create an entire video training series related to that issue or topic or concern. I figure that if there is a doctor anywhere who has an issue, a concern, a roadblock, a barrier, an obstacle, well, there's probably many other doctors struggling with the same issue. And so I would love to hear from you and find out what your concerns are. And who knows, we may create an entire video training series related to that specific topic. So if there's something that we can help you with, I'd love to hear from you. Feel free to give me a call at any time at 800-676-8127, or you can email me at any time at admin@ezqmeceu.com. Now, with regards to carpal instability, a couple of points that I want to make. And one of those points has to deal with the physical examination. Now, in our clinical practice, we don't often assess for carpal instability. Carpal instability is one of the permanent impairments that's described in the AMA guides. Whereas in our clinical practice, we might do some physical examination procedures to assess for the general condition of a wrist sprain. The AMA guides require us to be much more precise in our description of injury to the wrist, particularly if that injury results in long-term instability of the carpal bones. And so it's important that with regards to our qualified medical evaluation examination, that we are familiar with the permanent impairments for each of the body regions, and that we specifically examine for the presence or absence of the permanent impairments. So if we know that carpal instability is one of the permanent impairments of the upper extremities, then our physical examination needs to include a complete procedure for the assessment of the presence or absence of carpal instability. And so I want to share with you in this video series some of the physical examination maneuvers that we use, some of the diagnostic study tests that are required for the assessment of carpal instability, and I want to review with you some of the pathoanatomy involved with these injuries to the wrist. So this will be a two-part video series. For today, I want to go over some general philosophy regarding carpal instability. Then I want to have a brief anatomy review with you so that we're all on the same page as to what the AMA guides is intending with their descriptions of carpal instability. And then in video number 2, we'll go over the physical examination maneuvers associated with assessment of carpal instability. And then after that, we'll get on the computer together and we'll pull up a set of wrist x-rays on a bona fide examinee. And we'll go over the wrist x-rays and the specific measurements that are required by the AMA guides for the assessment of all the different gaps and all the different angles and all the different measurements that are required for the assessment of carpal instability. So this is going to be a fascinating and a complete course. It's going to be a fascinating review, and it's going to be really a complete course on the subject of carpal instability. So to begin with, I just want to go over a couple of general principles from the AMA guides. So I'm going to ask you to pull out your AMA guides and turn to page 502 if you would. And in the second column, the AMA guides describe carpal instability, and they describe what's required of us as examining doctors. So I just want to read a couple passages here to establish the philosophy of today's presentation. Okay, so the AMA guides tell us that carpal instability patterns are classified as mild, moderate, or severe. Mild, moderate, or severe. So we can have mild instability, moderate instability, or severe instability. And the AMA guides provide for different levels of permanent impairment depending upon whether the instability pattern is a mild instability, a moderate instability, or a severe instability. They then say that the classification, that is the classification of mild, moderate, or severe, is usually based on the röntgenographic findings listed in table 1625. They say the classification is usually based. Usually based. Now, what's the opposite of usually? What does usually mean? Usually means not always. So herein, the AMA guides tell us that we have the latitude to go outside of the röntgenographic findings listed in table 1625 if in our clinical judgment other criteria, other parameters more closely describe or more accurately describe the instability pattern. So here the AMA guides gives us some latitude outside of the X-ray findings. And they give us a couple of examples where we can exercise our latitude. They say that a mild, a quote-unquote mild carpal instability exists also when a ligament tear has been diagnosed by arthrogram, arthroscopy, or MRI, even though the static röntgenographic findings may be normal. So let's think about this. We have a an examinee who has MRI descriptions of a ligament tear in the wrist, but the static x-ray findings, where we go through all of our measurements, all of our angular measurements, all of our gap measurements, those findings are normal, we still say that the applicant or the examinee can qualify for a mild carpal instability. So herein the AMA guides tell us that they rely heavily on the Röntgenographic findings for the determination of mild, moderate, or severe instability, but we have a couple of other criteria that we can exercise as well. And then finally, they give us another criteria and another latitude that we can exercise. They say that certain individuals may have wrist pain and loss of strength related to a dynamic, that should be in quotes, should be dynamic, quote unquote dynamic, or quote unquote non-dissociative carpal instability that cannot be measured by changes of angles on standard static Röntgenograms. So herein the AMA guides establish their philosophy with regards to carpal instability. They state that for the most part they're mostly concerned with the dissociative type of carpal instability. And we'll define dissociative and non-dissociative here in a minute as we go. They're primarily concerned with the dissociative type of carpal instability, and they provide an entire table, that's table 1625, that gives us permanent impairment ratings for several of the different types of dissociative carpal instabilities. But they tell us that we have the latitude and we have the option of providing for permanent impairment in those cases where there's a non-dissociative type of carpal instability. For example, an examinee who simply complains of wrist pain and loss of strength, an examinee who has a ligament tear on MRI but no changes or no signs of dissociative carpal instability, we can provide for permanent impairment for those as well. And this is where I say that the permanent impairments related to carpal instability are somewhat underused, especially in these exceptional cases that the AMA guides allow us to exercise. Okay? Well, they say that with regards to the non-dissociative types of carpal instability, where we are not as often exercising our latitude as we should, could, or would, they say that symptoms of non-dissociative wrist instability are, number one, painful clicking, and two, clunking with activities of daily living. So there they give us a sign of the type of examinee who could qualify for permanent impairment, at least due to a non-dissociative type of carpal instability. They say the person may have wrist pain, may have loss of strength, and they may have painful clicking and clunking with activities of daily living. So this describes the different types of carpal instability cases that we will commonly encounter in our evaluations. We'll have those examinees who have clear-cut evidence of the dissociative type of carpal instability. We'll have those examinees who do not have clear-cut evidence of a dissociative type of carpal instability, but who have rather what we would consider to be a non-dissociative type of carpal instability. And both of those can qualify for permanent impairment under this section. So let's go over these different types of carpal instabilities with a brief anatomy review. So we'll take a quick break right here, and I look forward to being back with you in just a couple moments as we review the important anatomy related to carpal instability. have a brief anatomy review of the important structures involved with carpal instability, and we're going to keep this fairly simple, only to the depth as is required by the AMA guides. So let's consider the palmar view of a left hand, and let's diagram that out and review these important instabilities. So here we have the radius bone, and right next to it we have the smaller ulna bone. So this will be the radial styloid process, this would be the ulnar styloid process. We're looking at a palmar view of my left hand. Okay? Well, let's diagram in the carpal bones. Here we have scaphoid bone. Here we have the lunate bone. Here we have the triquetrum bone. And then over here we have the pisiform bone. And these are the proximal row of carpal bones. We have scaphoid, lunate, triquetrum, and the pisiform. And those form the proximal row of carpal bones. Well, then we have the distal row of carpal bones consisting of the trapezium, the trapezoid, the capitate bone, and then the hamate bone. And this forms the distal row of carpal bones. And then, of course, off of those, we have our metacarpal bones, first, second, third, fourth, and fifth metacarpal bones. This is a palmar view of the left hand. Okay? Well, it's interesting when we're talking about the ligamentous structure of the carpus of the wrist and the hand. We're going to see that there are many overlapping layers of ligamentous stabilizations. So, for example, the proximal row of carpal bones is stabilized by interosseous ligaments. So, for example, here we have the triquetropisiform ligament. This is known as an interosseous ligament. We have a lunato-triquetral ligament. Here we have a scapholunate ligament. And the scapholunate ligament is going to be an important ligament for our discussion because disruptions of the scapholunate ligament give us many of the carpal instabilities described in the AMA guides. Now, the scapholunate ligament actually has three components. It has a palmar component, it has a dorsal component, and then bridging the palmar and dorsal components is a proximal component. Well, we can't draw in the dorsal component, but we can draw in the proximal component, which would look like about like this. And we'll diagram that in with a different color. So notice here that the proximal row of carpal bones are all interconnected and stabilized, one bone to the next, through thick interosseous ligaments. And the same situation, of course, applies to the distal row of carpal bones. So here we have a trapezium trapezoid ligament. Here we have a trapezoid capitate ligament. And here we have a capitate hamate ligament. So here we see the proximal row of carpal bones all stabilized. We see the distal row of carpal bones all stabilized. Isn't that amazing? Okay? That constitutes what we consider our first level of ligamentous stabilization. The second level of ligamentous stabilization is a stabilization of the proximal row of carpal bones with the distal row of carpal bones. So let's take out a different color and stabilize the scaphoid with both the trapezium and the trapezoid. And that is the scaphotrapezium trapezoid ligament, stabilizing the radial half of the proximal row of carpal bones with the radial half of the distal row of carpal bones. We have also a piezohamate ligament, stabilizing the ulnar side of the carpus. We have a triquetrum hamate ligament, and we have a triquetrum capitate ligament. Notice the stabilization of the proximal row of carpal bones now with the distal row of carpal bones. Now, noticeably absent from this diagram is a stabilization from the lunate bone to any one of the carpal bones in the distal row. And this is going to create a potential instability here related to the lunate bone. And it's interesting because the AMA guides, when we get into table 1625, they describe 5 different measurements that we need to assess for the presence or absence of these dissociative carpal instabilities. So one of the measurements is a measurement of the radiolunate angle. One of the measurements is a measurement of the scapholunate angle. One of the measurements is a measurement of the scapholunate gap. One of the measurements is a measurement of the lunato-triquetral gap. And finally, there's an assessment for ulnar translocation, which involves movement of the lunate bone. All of those measurements and all of those assessments are focused on the lunate bone. The lunate bone is the key culprit in the instability syndromes, at least those that are described by the AMA guides. And the reason is the lunate bone is the most unstable of the carpal bones, largely due to this lack of stabilization between the proximal row or the proximal lunate and any of the carpal bones on the distal row. Okay, interesting. Okay, well, the plot thickens from here. We now have the proximal row of carpal bones stabilized by the interosseous ligaments. We have the distal row stabilized with interosseous ligaments. We have ligaments spanning the proximal row to the distal row. Well, what about in here, the radio and ulnar carpal joints? This is the radio and ulnar carpal joints. Well, we have some stabilization from the radius to the scaphoid bone through the radioscaphoid ligament. We have stabilization from the radius to the lunate with a short radio-ulnar ligament and also a long radiolunate ligament. We have stabilization from the ulna to the triquetrum through the ulnotriquetral ligament. And then we have stabilization from the ulna to the lunate with the ulnolunate ligament. And then amazingly, we have stabilization from the radius through the lunate into the triquetrum with the radiolunotriquetral ligament. Isn't that incredible? So now these ligamentous structures stabilize the proximal row of carpal bones. What's left? What could possibly be left in terms of ligamentous stabilizations between the radius and ulna, the proximal carpal row, and the distal row of carpals? Well, amazingly, we have a series of ligaments, a pair of ligaments that stabilize the radius and the ulna now with the distal row of carpal bones. So for example, we have a radioscaphocapitate ligament. Radioscaphocapitate ligament. stabilizing the radius to the scaphoid and the scaphoid to the capitate. Similarly, we have an ulno triquetral capitate ligament, stabilizing those three bones together. And notice this gap in the middle where there's a lack of stabilization of the lunate bone. This space right up in through here is a named space. It's known as the space of Poirier. Poirier. And that describes a space of potential instability and a space where the lunate has the opportunity to sublux and even dislocate in these traumatic wrist injuries. Now the AMA guides describe three types of instability patterns. Number one is the dissociative. Dissociative carpal instability. Number two is the non-dissociative. And number three is ulnar translocation. Translocation. Okay? With a dissociative carpal instability, we're mainly looking at disruption of the scapholunate and or lunato-triquetral ligaments due to injury to the scapholunate ligament or injury to the lunato-triquetral ligament. So those would be due to injuries here. Okay? With our non-dissociative carpal instabilities, we're looking at injury to the ligaments that bridge the distance between the proximal and the distal row of carpals. So that could include injury to the radioscaphocapitate ligament, injury to the ulno-triquetral capitate ligament, or injuries to the interosseous ligaments between the proximal and the distal row of carpal bones. And then finally, the AMA guides describe ulnar translocation, which is where the lunate bone, which should lie at least 50% of the lunate bone should lie over the radius bone. In this case, I have about 90% of the lunate bone lying over the radius bone. Well, with ulnar translocation, the lunate bone subluxes ulnarly due to injury to the ligaments between the radiocarpal joints or the ulnocarpal joint ligaments. So those would be injuries here, or injuries here. Okay? So there's a lot going on in the carpus and a lot of interosseous and spanning multi-level ligaments. Well, as far as the AMA guides go, there's a couple important kinematic principles that we can rely on for our physical examination and also later on for our radiographic assessments. And that is that with the movements of flexion and extension of the wrist, flexion and extension is shared equally between the radiocarpal and ulnar carpal joints and the proximal and distal row of carpal joints. So when we consider the entirety of the range of motion of flexion and extension of the wrist, that motion is shared between these major articulations. It's about a 50-50 ratio. So that's one thing. The second thing is, and I know this diagram is getting a bit busy now, is that the scaphoid and the triquetrum have unique mechanics and unique movement patterns. Now, when the wrist undergoes a compressive load, or when the wrist flexes, or when the wrist goes through radial or ulnar deviation. Because of the shape of the scaphoid bone and because of its proximity between the trapezium and the radius bone, when, for example, the wrist goes through the movement of radial deviation, as the trapezium approaches the radius bone, the scaphoid bone has to get out of the way in order to allow full range of motion. The scaphoid does that by flexing in the palmar direction. And you can actually feel that yourself. If you take your fingers and palpate just below the radial styloid process, you'll encounter there the scaphoid bone. And as you take your wrist through radial and ulnar deviation, you'll feel the scaphoid bone move, so that when you go into radial deviation, you feel the scaphoid come out against your thumb. That's the scaphoid palmar flexing. Palmar flexing. Well, when you go into ulnar deviation, the scaphoid dorsiflexes, and you can feel that if you just do this exercise here. I feel it right here. The scaphoid is poking out against my finger as I go into ulnar deviation, is poking into my thumb as I go into radial deviation. Same thing happens with wrist flexion. The scaphoid palmar flexes. The same thing happens when the wrist is under compressive load and the distal row of carpal bones start to approximate the radius and the ulna. The scaphoid has to get out of the way. So that's going to be the basis for our radiographic studies that involve the closed fist or the clenched fist stress view. The clenched fist applies a compressive load to the scaphoid bone, causing the scaphoid bone to palmar flex. Well, as the scaphoid bone is palmar flexing, the triquetrum bone is dorsiflexing. So you can demonstrate that to yourself as well. If you just palpate immediately beyond the ulnar styloid process, you will encounter the triquetrum bone. It's kind of tucked in under there underneath the pisiform bone. But if you ulnar deviate your hand, ulnar, you feel the triquetrum bone poke out against your thumb as the triquetrum bone palmar flexes. With radial deviation, you feel the triquetrum bone poke out against your finger as the triquetrum now dorsiflexes. So this is an opposite movement pattern as to what we're seeing in the scaphoid. As the scaphoid, here's the scaphoid, here's the triquetrum. As the scaphoid palmar flexes, the triquetrum ulnar flexes, dorsiflexes. As the triquetrum palmar flexes, the scaphoid dorsiflexes. There's a counter-rotational movement between the scaphoid and the triquetrum. Isn't that incredible? Well, what does that mean for the lunate bone? What does that mean for the lunate bone, which is firmly adhered to the scaphoid through the scapholunate ligament, and it's firmly adhered to the triquetrum through the lunato-triquetral ligament? Okay? So as the scaphoid palmar flexes, it wants to drag the lunate along with it because of this strong ligamentous attachment. If this strong ligamentous attachment is disrupted, if there's a ligament sprain, a ligament rupture, then the lunate will be left behind. And that's something that we can measure on our static röntgenograms as we go through the stress clenched fist view. Well, as the triquetrum moves in the opposite direction, so as the triquetrum, let's say, dorsiflexes, it wants to drag the lunate along with it through this strong ligamentous attachment. Well, what does that mean? If this ligamentous attachment is disrupted, then as the triquetrum dorsiflexes, the lunate would be left behind because of its connection with the scaphoid bone. And we can pick that up on our measurements on the static Rankinograms. So the lunate is going to be the focus for our assessment and our measurements for the assessment of carpal instability, both on our physical examination and also on our static Rankinograms. So on our next video, I'll go over with you the physical examination maneuvers that we employ for the assessment of carpal instability, and then we'll go to the computer and I'll pull up a set of wrist x-rays on a bona fide examinee, and we'll go through those views one by one. We'll do those angles and measurements together, and together we'll come up with an assessment as to whether or not our examinee qualifies for permanent impairment due to carpal instability. So I hope this brief review on philosophy and anatomy helps you. I look forward to being with you on our very next video. And for now, this is Dr. Perry Carpenter. I'm wishing you best of success in your career as a qualified medical evaluator.